Recording in progress.
I hope my slides are visible. Anyone, please unmute yourself and let me know. My slides are okay. Thank you, and I'm audible. Fine. Okay. So today we will learn about the knee joint. But before going into the sonoanatomy, pathology, and the intervention, we need to understand what exactly do we mean by knee joint, right? So when we say knee joint, this is a synovial articulation between the distal end of the femur and the upper end of tibia, okay? So this is going to form a joint, right? And we have another articulation between the femur and the patella, right? We do not have a participation from the tibia and the fibular joint when we are going to talk about the knee joint, right? So when you look at the patella, it is very important for you to understand how exactly the patella is, how exactly it looks like to you, because this is very important. So if I'm seeing the patella from the anterior aspect, you can see that it has got something which is rounded here, and then it is the apex, which is just pointing down, right? So this, we are going to call it as the base of the patella, and this is the apex of the patella, right? Now, if you want to see the apex, it is not only just a pointed thing, it just broadens up on this side as well. And there is a significant finding why we should be looking for it, not only the tip, not only the, I should say, the two lines where they are meeting up, but yes, we need to look at the broader aspect of it when it is fanning out as well. Why? Because when we are going to look at the patellar tendon, it does not take its origin from this apex itself. You have attachment from the side as well. So if you really want to look for the patellar tendinopathy, we need to evaluate it fully. And that is the reason of understanding why not only just the apex which matters to us, but as it broadens up, that at the distal end of the femur, right? So today, since I'll be taking only the medial side, so we'll concentrate more on it, right? So when you're looking at the distal end, right, you're able to see a projection from there, and then it is going down, right? So that is your medial condyles, and this is your epicondyle, the protruding part, right? Now, the cartilage which you are able to see, we are going to call it as trochlear cartilage, okay? And when you look at the tibia, so the tibia upper portion is flat, but just have a look at the condyles of the femur. They are rounded. So one is rounded, another one is flat. So in order to increase the stability of the joint, we need to have something, right? Otherwise, what will happen? A knee joint is going to be in just an unstable joint, right? So what all structures do we have? You'll be learning in a while. But before that, you just understand the bony anatomy of the tibia as well. So if you're going to see this bumpy thing, which is there on the anterior aspect of the tibia, so this is your tibial tuberosity. Again, it is very important because this lies because you're going to have the insertion of the patellar tendon, which will be on the tibial tuberosity. So that is the reason you need to understand this bumpy thing, right? So what all we have understood from these two slides is femur condyles are rounded, tibia is flat, right? And your patella base is up, apex is down, and you need to see the apex becoming broader up fully, right? Not only you need to scan just the tip, but yes, we need to scan it nicely on both the aspect. Then you should know about the tibial tuberosity, fine, and the trochlear cartilage. Now we have already seen our previous slide that this tibia surface is flat, femurs are rounded structure. So in order to increase the stability, we are having a fibrocartilaginous structure. And this we are going to call it as meniscus, okay? Deliberately, I have not kept ACL because ACL is not the ultrasound is not the diagnostic modality of choice when it comes to your ACL injuries. though it is not for your meniscus also. But yes, few things which you can very well see about the meniscus. This portion of the meniscus we will be able to find out, and that is the reason I have just kept it here. And we do have the anterior and the posterior cruciate ligaments, which prevents the translation of the tibia over the femur. Okay. So once we have seen all those bony things, then let's come out of this. And the first thing you are going to see is your synovial membrane. Okay. And then is the capsule. So what you need to remember here about the synovial membrane is this synovial membrane will be having a proximal extension. And this proximal extension, we are going to call it as suprapatellar recess. Okay. So suprapatellar recess is not a synovial sac. Okay. It is an extension of the synovial membrane itself. And that is the reason whatever we are going to inject here, it is going to spread to the whole of the knee joint. Okay. And of course, this is the capsule, which will be covering it from the anterior aspect. And we do have it on the posterior aspect, which will be covered in our next class. Then when you see the anterior aspect, you need to understand that there are 4 muscles. Okay. And these 4 muscles, they form a tendon. So this tendon name is quadriceps tendon, right? Again, go by the name. Quadri means 4. So you are going to have 4 tendons. Okay. Now, what all are the muscles which will be forming this 4 tendons? So we have vastus medialis, intermedius, lateralis. Okay. And on the top of this intermedius, we are going to have the rectus femoris. Now, what you can see here is this vastus name is common, right? And if you go from the medial side, it is medialis. Then you have intermedius, then you have lateralis. So easy to remember. Now, on the top of this intermedius, you are going to have the rectus femoris. And all of them, they will be forming a tendon. And this tendon will be attaching on the base of the patella with some fibers extending onto the top of the patella. Fine. Now, beneath that, you are going to have this muscle. This is articularis genu muscle. And this articularis genu muscle, it's take its origin on the anterior aspect of the femur, and it attaches to the suprapatellar recess. Fine. Then this is how it will look like in the short axis. So again, I have a mnemonic to remember it. That is the figure of 8. Okay. So you have to see here, rectus femoris, down will be the vastus intermedius, this side will be the medialis, this side will be the lateralis. Then when you are looking up for this quadriceps tendon in the sagittal axis, you're going to have 2 fat pads. Okay, so this will be the proximal side, that is the distal side. So this is femur, and then we have patella. So there is 1 fat pad which will be lying superior to the patella. So this is suprapatellar fat pad. One which is lying on the top of the femur. This is your prefemoral fat pad. We do have Hoffa fat pad or the infrapatellar fat pad, which will be lying beneath this patellar tendon. Then what is patellar tendon? So as I have told you, this will be the apex. So as you can see, the patellar tendon takes its origin not only from the apex, but from the sides, and it attaches itself on the tibial tuberosity. So that is your patellar tendon. And on the top of this patella, we are going to have 1 bursa. This name of this bursa is going to be the prepatellar bursa. And on the top of this patellar tendon, okay, we are having another bursa. And the name of this bursa is superficial infrapatellar bursa. Okay, because your patella must be somewhere here.
Ma'am, your audio is muted.
What happened?
Yeah, now audible.
So there is another bursa, and this will be lying beneath this tendon. Okay, so this becomes your deep infrapatellar bursa. So this is deep to the patellar tendon, and it is lying above this tibia. So it is deep infrapatellar bursa. That was another one which we have seen. That was a superficial infrapatellar bursa. So again, the moral of the story is you have the patellar tendon. One will be lying above it. One will be lying below it. So the one which is above the patellar tendon becomes the superficial. One which is deeper to it, it becomes the deep. Then on the medial knee, please read this article, one of the best article I have ever read regarding the layer structures. Okay. So when you go to your medial knee, you need to remember 3 layers. Okay, it's a 3-layer structure. The same applies to the lateral aspect. Okay, so if you go to the medial side, you have layer 1. So what is layer 1? It is the purple color. Okay, so you can see the purple color. What is this purple color? Purple color will be the medial retinaculum. That is going to form the superficial layer. Then when you go to second layer is orange color. So this is orange color. So what is there in the orange color? You are going to have the superficial medial collateral ligament. And along with that, we are going to have the medial patellofemoral ligament. So this is the ligament which will be from the patella, okay, going up to the femur, the medial condyle of the femur. And this is the one which maintains the stability of the patella. We do have it one on the lateral side. Okay, so it will be just, I should say the same thing which is there on the medial side will exactly be there on the lateral side as well, right? And when you go to the deep layer, it is the deep part of your MCL, okay? So this medial collateral ligament has got 2 parts. It has got a superficial layer and it has got a deep layer. So the superficial layer will be in the intermediate layer and the deep layer is obviously in the deeper layer. But if you remember here, the topmost layer is just the retinaculum. I'll teach you a very simple technique to identify the retinaculum, MPFL. So nothing to worry about. Okay. And the deep layer is obviously the deeper part of the MCL and of course the joint capsule. And this is how it looks like. Okay. This is also another good article which you can read. Okay. Very nice. There are some of the good articles which I really feel they have done good dissection. They have mentioned everything very nicely. Same. Okay. Okay. So once we have identified that, then we should know what is pes anserine. So pes anserine, how can you remember? It's like a goose, feet. That's what they say. 1, 2, 3 tendons. Okay. Tendons of what? One is your sartorius, which is a muscle of the anterior compartment. Then gracilis, medial compartment. Semitendinosus, posterior compartment, right? So you have 3 tendons coming and just getting attached on the tibia, okay, anteromedial aspect of the tibia. So this we will be seeing. Again, I'll be teaching you a simple technique, how to look for it very nicely, okay. So I think this much we will be covering today. So if you have any doubt, you can ask me, or else I will just start the demonstration. Any questions? Okay, then I will ask you lots of questions when I'm demonstrating.
Ma'am, I
Yes.
have a doubt.
Yes.
Yeah, good afternoon, good evening.
Good,
This is
good
Suhaila.
evening, good afternoon, good night, good morning. Yes.
Yeah. This pes anserine, these 3 muscles, no, all of them are attaching to the medial tibia.
Yes.
Which
Somewhere
part
here.
exactly, ma'am?
Here.
Tibial, tuber.
Okay. Oh. Somewhere here.
Mm-hmm.
Okay. I'll show you, don't worry. You will learn everything. Just
Okay, ma'am.
remember
Thanks.
3 and then you will see how easy they are. Okay, to find out.
All right, thank you.
So first and the foremost important thing is the positioning. Okay. So here he is lying down in a supine posture. Okay. And second thing is we need to keep something like you can see here, this one. This is a rolled pillow which I have kept beneath the knee joint. Why was it required? It is because I think in the shoulder class or some other class, you would have seen us teaching that whenever you want to look for any kind of tendon, so it is the opposite action you do. Okay, so that you are stretching it fibers and you will be able to see the tendons very nicely. So we have the quadriceps tendon, which is here going and getting attached on the base of the patella. So what is the action of this? It is an extensor. Okay. So if I'm going to flex it, this will be a little bit stretched, and I will be just eliminating the anisotropy, which if I'm not going to keep this pillow or roll sheet, anything beneath the knee joint to have a flexion of approximately 30 degrees, then what will happen? This tendon will be something like this. Okay. Sagging. So when you're going to put your probe, you might be thinking that, oh, there is some kind of, tear there because you will not be able to see the fibers nicely. So it is that much important when you are examining the knee. Fine. Then just have a bony landmark, rough idea, so that when we are seeing, you know exactly what we are looking at, right? So this is rounded one, obviously, like a cap. So this is the patella. And we have learned that the patella base is going to be up. So that is the base. And if I am going to just follow this, the borders, they are going to meet somewhere here. So this is the apex. Okay. And then if I go down, I'm just encountering a bumpy thing. So this bumpy thing is the tibial tuberosity. Okay. Now from the tibial tuberosity, if I'm going to keep my fingers, keep on going up, 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 up. So my finger is going to dip somewhere. So that is the medial joint line. Okay. So above that, if this is the joint line, obviously, this will be the condyle of the femur and this will be the plateau of the tibia, right? That is what we have seen. What is knee joint? It is a synovial articulation between the distal end of the femur and the upper end of tibia, right? So this is what we have seen and this is how we will be seeing it. Now about the medial collateral ligament. So ligament is something which will be connecting two bones, right? So we have one ligament on the medial side like this. So this ligament, do remember, like if this is your femur condyle, somewhere here will be the one tubercle, okay, adductor tubercle. So this goes from here. It is gonna go like this. So how you are supposed to move your probe? You are supposed to move your probe like this. If you are gonna move your probe like this, you will not be able to see this, okay? And the moment you will be moving your probe to see this ligament, you will be able to see these three tendons coming from the posterior aspect, and they will be lying on the top of the medial collateral ligament superficial layer. Okay, so this is what we'll be seeing today, roughly. And on the top, you're going to have the quadriceps tendon. So this will be the sagittal axis of the quadriceps tendon. This will be the axial section of the quadriceps tendon. This will be the patellar tendon, sagittal axis. This will be patellar tendon, axial section. Okay. Yes. So in order to look for the anterior knee, I am using a frequency of 20 megahertz, but I'm going to the setting of knee. Okay. I have kept a depth of 3 centimeter and I'll adjust it accordingly. So what you need to do, simple way to identify the quadriceps tendon without any, trouble is just palpate the base, okay, of the patella. So that is the base of the patella. Put one of your finger if you are new to ultrasound. If you are not new to ultrasound, do not do that. You will know where exactly you have to keep. Okay. So this is the base of the patella. You put the caudal end of your probe exactly over that. Okay. And the moment you will be doing that, you will be able to see something like this. Okay. So what we are seeing here, let me freeze it and then we will learn. So what did we do? We have kept our probe in the craniocaudal direction and we are looking at the sagittal axis of the quadriceps tendon. This will be the cranial side. Okay, my annotations are not on. So this will be the cranial side and this will be the caudal side. Since my probe was over the base of the patella, so this is going to be the patella. This bone, it has to be the femur, right? Now you are able to see something here going like this. Fine. So that is your quadriceps tendon. And beneath the quadriceps tendon, you will be able to see one fat pad here. Okay. And the another fat pad, this one. So these are two fat pads. And this is your articularis genu muscle. This is prefemoral fat pad, suprapatellar fat pad, and this river-like thing which you are able to see here is your suprapatellar recess. Okay. Simplify it. How can you simplify? We should be seeing two bones, right? What is two bones? One is patella. What is the other one? Femur. Okay. Then we are going to see two fat pads. Which are the two fat pads? One is suprapatellar fat pad. One is prefemoral fat pad. You are going to see one tendon. Which tendon? Quadriceps tendon. You are going to see one muscle. Which muscle? Articularis genu muscle. Okay. Again, you are going to see one recess. So that is suprapatellar recess. So the moral of the story is we are going to follow this rule. Okay. Or you can remember it, 1 square, 2 square. This is there in my recent book. Okay. So this mnemonic is very good to remember these structures. Okay. So we will learn more about the quadriceps tendon now. So quadriceps tendon is basically made up of 4 muscles, right? So how can you identify the 4 muscles? This is what we talked about. So for that, I will just, if this is the patella, 4 fingers of mine, okay, plus 2, 6, I'll just keep it somewhere here in the short axis, okay. So once I'm gonna do that, I will see something like this. So let me go to convex mode and I'll freeze it here. Right, 4 plus 6 fingers, mine are quite good one. So you can take yours as maybe 7, up to you. What exactly is the width of your finger, okay? So this we were seeing in the short axis, our probe was, the aspect marker was towards the lateral side. I always keep it how exactly the body is oriented. So this was the lateral side and this was the medial side, okay? So lateral, medial. Now what you are seeing here is the rectus femoris. This muscle beneath is the vastus intermedius. What you are seeing on the medial side is vastus medialis. What you are seeing on the lateral side is the vastus lateralis. Fine. So how can you make it? It is just like a figure of 8. Fine. Rectus femoris, vastus lateralis, medialis, and intermedius. Now, you can just make them 1-1 tendon. I'll just show you the rectus femoris. So this was the rectus femoris. And when you are looking at maybe in the hip joint, you would have learned about how exactly, because you have a direct tendon, you have an indirect tendon when it comes to rectus femoris. So do remember when you are looking at the rectus femoris, the tendon formation will be starting from here. Okay. So that is the muscle. We are going to have the tendon getting formed from this side. So just see it carefully. So if I'm following it down, 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 gone. Okay. So what you are seeing here is the tendon of the rectus femoris, right? And rest, everything is still a muscle, right? So this will be forming the superficial layer. Vastus lateralis and the medialis will be forming the middle layer, and this intermedius will be forming the lower layer, okay, third layer. So first layer will be by the rectus femoris. As you can see, it has already become a tendon. Second will be formed by medialis lateralis, and then will be formed by this intermedius. Now what you are seeing here, this muscle is your articularis genu. Okay. So if I'm going to come down, right? So you can see this is the second layer. Okay. So you can keep on following. So what is the point which I would like to show you here is, if I will follow it down, okay, more down, you will see that at this moment, the lateralis already has become a tendon. Okay. Now, if I just rotate my probe towards, if I'm rotating my probe towards the medial side, vastalis medius, okay, vastus medialis will still be a muscle. This is very important because you are going to have a distal expansion of this muscle, right? But that will not be the case for the vastus lateralis. Fine. That is the one important thing which you should know. And the other thing which you should know is how to identify the suprapatellar recess in the short axis. Okay, because in the long axis, we have seen it, but in the short axis, supposedly there is no fluid and you want to put a needle there, then what exactly, how are you supposed to identify? So here, when you are putting the probe, right? Once you are seeing this quadriceps tendon, okay, so you might be seeing some all hyperechoic structure. Here also hyperechoic, here also hyperechoic, and you are confused because one is your prefemoral fat pad, the other one is your tendon. Some book says that, you can just make use of anisotropy. So the fat will be, remaining as it is. The anisotropy will be exhibited by the tendon. That is one way. Second way, which is my way, okay, I follow this tendon distally until I see the patellar fat pad hanging down from it. Okay, so just follow this. You will see something will be coming down now. This will not be there if I'll go up. See, it has gone. Now it will come. It has come. Now it will go. It will come. Right? So by default, I know that okay, I will freeze it here. So this is what I was trying to tell you. So that is your suprapatellar fat pad. That is your quadriceps tendon. You are going to have your prefemoral fat pad here. So this should be the recess. Okay. So you can identify it in that manner. And if you will, poke, like you can just try to mimic as if you are poking a needle from the lateral side. So let me do that. So we were here, now we are coming down, 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 down. And you will see something which will be hanging down. So this is hanging down. And if I'm going to poke my needle, see, this is a prefemoral fat pad which is moving. Okay. And now I'm able to see even the recess better. So that is fat pad, suprapatellar, see, which is coming and going, concentrate on something. See, it has come. Now it has gone. It has come. It's gone. So this is your recess. So three ways I have told you. One is to look for the anisotropy. Second is to look for the hanging suprapatellar fat pad, because you have the suprapatellar fat pad, then the recess, and then the prefemoral fat pad. This is what we have seen in the sagittal section. Third thing is you poke it from the lateral side. Okay. So the prefemoral fat will be dancing. And on the top, you will be able to see the recess. This recently I just read in one of the article and I found it very good. So that is also one thing which you can follow. Right? So once you have seen everything there, now we will be moving to the vastus medialis. Now put your probe again back to the position 7 fingers above. Now concentrate only on the vastus medialis and let us increase the depth. Okay. So this is vastus medialis. Okay. That is the femur in the short axis, because my probe is in short axis to the distal end of the femur with the aspect marker towards the distal side. Now do nothing. Just keep on coming down and just keep on looking at your vastus medialis. That's all you have to do. Okay. So I'm coming, down, down, down. Now I will reduce my depth. Okay. I'll go back. I got lost. No jelly, so no transmission. So again, this was the Vestus. Okay, so we were here almost, we reached here. And then keep on coming down. So once you are coming down, one moment will come when you will see this Vestus has gone. Okay, fully. It is not there now. Right? So here I will try to angulate my probe. And I will freeze it here. So when I was just coming down, I told you first layer, this will be the retinaculum. Okay. And what you are seeing here, that is your MPFL. This is your femur. This is your patella. And how was the probe? Lateral to medial orientation. That's why patella is on this side. So if you want to look for the retinaculum, whether there is any break in the retinaculum, the medial retinaculum, because all these are just the medial stabilizers of the patella. Okay. So if you are just thinking of any kind of, instability of the patella, so that time you need to evaluate it. And this is the best possible way. Okay. Just to identify them in one go. Don't do anything. Just follow the Vestus medialis, let it disappear. The moment it is going to get disappear, because the retinacular fibers, some of the fibers, they just come from them, the medial Vastus medialis. Okay. So you will see that everything is gone and it is only the hyperechoic, structure which you will be able to see. And that is going to be your retinaculum. Then we go back again to where we were. So we were over the base of the patella. So now what I will do is, I'll come back. We were here. Oh. So we were here, okay, like this. Now, if I can just toggle it, I can show you. Okay, let me increase the depth a bit. And freeze it here. Do not means, it should be a dynamic evaluation. So this is going to be the superficial layer. This is the intermediate layer. This is the deep layer. This is the intermediate layer, and that is the superficial layer. Okay. So quadriceps tendon is basically a trilaminar structure, right? So you go back. Today I have shown you the rectus femoris, right? How it is becoming the tendon. Because if this is the rectus femoris, do remember the tendon starts from this base, not from the top. So don't look for that. Okay. So you can just see it. Then you can follow the vastus medialis and you can see where it is getting inserted. Same thing with the lateralis. So you can practice, right? And do remember that this is a trilaminar structures, right? You can just make use of the anisotropy. So this tendons, because they are tendons, they will be exhibiting the anisotropy and you will be able to make up the fibrillar pattern. Like here, you are able to make up, and this becomes, the intermediate becomes fully black because my beam was not oriented. And this is very important that you should be seeing the 3 layers, right? If there is a problem in one of the layer, we will see what exactly happens in the pathology section. And once you have done that, okay, you just come maintaining the same orientation, craniocaudal. So we were here, okay. So now, again, you can appreciate, you can just toggle your probe and you can just keep on toggling your probe and keep on appreciating the layers, okay. Then once you are coming to this side, you will see that it is the superficial layer which continues over the patella, okay. So this is the patella and you are seeing that the superficial layer, that is of the rectus femoris, it continues on the top of the patella. So when you are looking at the patella, try to evaluate it nicely, okay. You just go and just scan it on the, the longitudinal axis. Then you can just rotate your probe and you can evaluate it in the short axis as well. Okay. Fine. So now you will be able to see that is the fibrillar pattern here, okay? And if you are having any kind of bursa, so this means any bursal enlargement, you will be able to see in the subcutaneous layer. So right now, I'm looking at the short axis, okay? Before, I was looking at the longitudinal axis. So longitudinal axis was like this, and this is the short axis, okay? So I was looking in the short axis. So look at this hyperechoic, the bone very nicely. Sometimes you might be seeing something like this, okay? So let me tell you. What are erosions, which I think in any of my class I would have taught you. If there is a bone, there'll be a break, okay, down. So that will be erosions. But sometimes here you will be seeing something like this. Do not think this is erosion. They are nutrient foramen, okay, which will be present in your normal bone also. So until and unless, you know this, you might be thinking, oh, these are erosions which I'm seeing. So this patella, this patient is a patient of rheumatoid arthritis because I'm inflammatory arthropathy, to be very specific. No, we do have the nutrient foramens, and you need to remember where exactly we should be looking for it, right? Okay, so that is one thing. So we have now evaluated the quadriceps tendon. We have looked for the fat pad. We have looked for the rhesus. We have looked for the medial retinaculum, the MPFL, right? These we have evaluated. Even we have evaluated the patella as well. And we have looked for the bursal enlargement there also. Now, once you have identified that, we are going to come down. So we'll bring our probe. Again, same, I'm not changing. My home page position will always be my probe in the craniocaudal direction, okay? So I'm looking at the sagittal axis. Now, once I'm just coming down, so this was the patella I evaluated, and then you can look for the starting up of the patellar tendon, okay? So that is the patellar tendon which is starting up. This is the apex of the patella which we are looking at. And now I'll be just going down, and once you are going down, you will be able to see the patellar tendon, okay? This is your fat pad. That is the tibia which is starting up. So once you have identified that, keep on coming down and take some jelly, apply it there, okay? So again, back, we were here. So I was coming down. Now we have learned from our, anatomy that it attaches itself on the tibial tuberosity. So you need to evaluate it fully till you are able to see the bumpy thing. So now you can see the attachment of the patellar tendon. Don't stop here itself. You need to go a little more, okay? Just in order to see the insertion of this tendon very nicely. So here you will be able to see that it has got inserted, right? Now, if you can just see it carefully, so you will be able to, let me show you, he has got some physiological fluid. I will freeze it here. So we learn about the superficial and the deep infrapatellar bursa. So this is your patellar tendon. There is another one, right? So if this is the tibia, you are going to have, I have a picture, so I'll show you how beautiful it looks like, okay, when it is enlarged. So this will be the site for the deep infrapatellar bursa. And in the subcutaneous plane, you will be able to see the superficial infrapatellar bursa. So deep infrapatellar bursa, superficial infrapatellar bursa, who is the common friend of these two is the patellar tendon, okay? Now, once you have evaluated the patellar tendon, what did I teach you? Because now we are learning how to evaluate the structures very nicely. So you need to go, towards the medial side, evaluate it fully, okay? This is what you need to do. And then you come back to the midline. Again, you evaluate it fully, okay? See. This is the way you should be evaluating whole of the tendon by, just moving your probe to all the aspects of the tendon, okay? Supposedly you are finding it too lazy to do that. What you can do, you can just look at the short axis by looking at the axial section of the patellar tendon. Now in this position, aspect marker is towards the lateral side. So we are looking at the, short axis of the patellar tendon. And this is the best one to look for because you will be able to see whole of the patellar tendon in one go. This is fat pad, okay? And this is your patellar tendon. So you can just swipe it very nicely and you can just look for whole of the tendon and you can just make out the pathology. And this is one of my preferred technique if I have to go for any kind of intervention of the patellar tendon. I do not do it in the longitudinal axis because the needling is very difficult, but in the short axis, it is very easy. So once you have evaluated whole of this, we will be shifting to the medial compartment. That's all for the anterior compartment. Mali, flex that's. So now I have just done the external rotation of the hip so that I'm able to see this side nicely because now our target is the medial. Okay. So medial, what you can do is, again, I have taught you, if this is my joint line, obviously, this is going to be the condyle, okay? And if I will just move a little more from there, I will be able to see again a bony thing. So that will be the adductor tubercle, okay? What you can do, you put your probe directly there in the short axis. Short axis means aspect marker towards me. So the moment you will be able to see, you will be able to see something like this. Okay. This is very important. So what we are seeing the medial collateral ligament in the short axis. Okay, this is also very important to look for it in the short axis rather than only the long axis. You should always look for it in the short axis, toggle your probe and everything will become fibrillar. Okay. So the moment you have seen it in the short axis, now the time comes to look for it in the long axis. So long axis means aspect marker towards the patient's head. This is the one thing which I always palpate in a, okay. So now what we are seeing, we are basically seeing the origin of the medial collateral ligament, okay. This hole is your medial collateral ligament, superficial layer, okay. Now if I go, now what you have to do, we'll just slide our probe, okay. And once we are sliding our probe, you can just toggle your probe like this. Now, one very important thing which nobody should forget. So let me just show you. Okay. Now, this will be your superficial layer which is going. Okay. And this is your meniscofemoral. And the other one is your Dr. Nicholas, I'll come back to you once I finish the demonstration. Okay. And this is your meniscofemoral part, and this will be your meniscotibial part. That will be your superficial layer. This is your subcutaneous layer, and then the skin. One very important thing is meniscus hopping. Okay. Why is it important? Because sometimes what happens, we are not able to understand whether there is any kind of meniscus pathology or not. If your meniscus is perfectly normal, okay, so when I will be flexing the knee, it should go inside. This is called as, this we call, in ultrasound as meniscus hopping, okay. Supposedly, instead of coming, it is going up. That is your bulging, okay, of the meniscus, right? Now we'll see this. This is very important. So I will keep it again back. Okay. So that is my meniscus. Now I will just flex the knee. So it is going inside. Okay, my probe is here. Are you able to appreciate?
Yes, ma'am.
No. Okay. See, if I go to 90°, it will be there only. Okay. But if there is any kind of pathology, you will see that it will bulge out. Okay. So if you really, because see, ultrasound is again not the diagnostic modality of choice to look for any kind of meniscus tear, because you do have an anterior horn, posterior horn. So you will not be able to see them very beautifully. But still, you can just tell, your colleague that yes, this patient has got some kind of problem with the meniscus. You do this. This is very, very important. Okay. So fine, we'll go back to our medial collateral ligament. Okay. So now I think you will be able to see the superficial and the deep layer. All of you, anybody? No? No answer. You all want to keep quiet. You don't want to answer. Superficial layer, and this is the deep layer. Sometimes you might see a bursa in between these two, and we usually call it as Boschel's bursa. Fine. Then what you are supposed to do? You follow this. See how beautifully it is coming down? So that is the superficial layer of the one which is coming here. That is your inferior genicular nerve and the artery. So you follow it, and you are just following it. And once you are seeing it's, you are just following it, you will see that there are some bulges here. 1, 2, and 3. So now I'll make use of anisotropy. I will just see whether they are becoming some kind of tendon. So are you able to appreciate? I promised to someone that it will be very easy to identify the pes sensorin tendon. Is it easy or not?
No, they appear
Not
clear
easy?
now.
Pardon?
No, they appear clear now.
Clear?
Yeah, it's clear now because before it wasn't
Oh.
clear, but
See, that's what I'm telling. It will be black. Okay, as if there is some bulge over the medial collateral ligament. Then you toggle your probe and try to make it look beautiful. Okay, that is what I was telling you. If you toggle your probe, you will be able to see it nicely. So we'll see it once again, because pes sensorin tendon, everybody finds it so difficult to look for, but if you will just toggle your probe and try to look for those small tendons, because we are looking at their short axis, you will be able to see it very nicely. So again, we'll go back to our meniscus. Means our, the medial collateral. Okay, I will do nothing. I will just bring it and just see the probe orientation. This is also important. Okay, if you will bring it like this is not the right manner. Your probe needs to be like this. So let me change the settings so that I can show you better. This is going to give me a good view. Better than what we are seeing. Yes, that is fine. Okay. Oh, too much of gain. Let me reduce it. So we'll come here. Now here, are you able to see this bony things? This black, okay, I'm drawing it there. This black shadows. So when you are seeing this black shadows, then you just toggle your probe, okay? And now you will be able to see. Are everyone able to appreciate the tendinous thing? It is very small, but it is visible. Okay, it is sartorius, gracilis, and semitendinosus. Now, if you want to look at their long axis, okay, so I will just show you one tendon. The rest we will come from the posterior aspect. So now what you need to do is if this is the cranial end, you try to tilt it towards the posterior aspect. Okay, that's all you have to do, because that is how your tendons are coming. So you are supposed to align them like this. So let us see whether we will be able to do it or not. Fine. Now, if I will go more, I'm able to see the tendinous insertion. Everyone able to appreciate? This is basically the sartorius. Fine. And beneath that, you are going to have your collateral ligament. But once there is some kind of bursal fluid there, it will be very easy for you to identify, because I'll show you a pathology picture. Okay, I have a picture. So you just see it very nicely and you will be able to appreciate it so beautifully if you are having a problem in your pes sensorin bursa, right? So these are the tendons, and then we are going to have the bursa, which will be there. And when there is a fluid, it becomes like an alphabet E. Okay. So that's all, I think, for the medial side. Let me come back to Dr. Nicolas. Clarify a bit fat pad from the tendon and other structures. I couldn't get your question. Could you please tell me what exactly you want to know?
Yes, ma'am. I just want to know when you scanning. I don't want prefer to use the word confusion. I could identify easily the tendon, but the part fed. The fit pad, that would be difficult for me because it wasn't clear.
You joined late when I finished that? Or you were following me from the beginning?
Oh, I think I might have connected maybe 10 minutes or so.
Okay. So I was actually showing you somewhere here. Okay. When we were looking at the quadriceps tendon in the short axis. So we have two fat pads, suprapatellar fat pad. How exactly the things? Okay, I'll show you in the sagittal section. As it's straight. So we have seen something like this. Okay. So let me go back to my knee setting. So I have shown you something like this. Okay. Are you able to appreciate, Dr. Nicolas? Could you please tell me what are the structures we are seeing here? Can you tell me? No?
Sorry, a bit noise with my generator here.
Okay.
But anyway,
See,
I don't want to
this
disturb.
is what we were seeing was the quadriceps tendon. Okay. Now this was the fat pad. This was the prefemoral fat pad. This is articularis genu muscle, and this was the rhesus. Okay. So I was telling you that if my probe is in short axis somewhere here, right? So if my probe is in short axis here, then what I should see? I should see the quadriceps tendon. Then I should see the suprapatellar fat pad. Then should be the rhesus. Then should be the prefemoral fat pad, right? So if this is my quadriceps tendon, this is prefemoral fat pad. This is also suprapatellar fat pad. So one thing is, like, when I'm seeing these structures and I have to look for this rhesus. This rhesus I need to find out because I have to inject here. So what I can do is, what I was teaching you that you look for the quadriceps tendon, then look for something which is hanging out from this tendon. So if something is hanging out, definitely it is going to be the suprapatellar fat pad. And beneath that, we are going to have a rhesus. Second is, we can just toggle our probe little bit because the anisotropy exhibited by tendon is maximum as compared to any structure in our body. So we have tendons, we have ligaments, we have muscle, we have nerve. This is how the anisotropy goes on, right? So we can make use of anisotropy. So the tendon will be just changing its eco-texture, but the change in the eco-texture of this prefemoral fat pad is not going to be that much. This is what I was telling you, and this is what I will be showing you now. I hope this much is clear to you.
Yes, now I'm working
Now
out
it's clear. Okay, so now we will
Yes.
see the same thing. Okay. And this suprapatellar fat pad hanging, it is not there in any of the books, right? So, it is just, once you practice, sometimes, you feel that this is much easier than anything else. And this is how I have realized that this technique is much better than the other one. So if he has done the external rotation, so my quadriceps has come to a different level. Okay. So now I'm just following the quadriceps tendon, okay? And I will show you the fat pad. Okay. So now concentrate on this structure, okay? This will go off if I will go up. Gone? It will come back. It has come. So means if this is my suprapatellar fat pad, this is my prefemoral, this should be the rhesus. Right? Supposedly you don't want this technique. Then what you can do is you can just toggle your probe and you can just look for the change in the eco texture. Okay. So the change in the eco texture of the tendon here will be more. This is your fat pad. It will not be that much evident. Okay. See, it is still looking hyperechoic to you. So that is another one. So means that also you can use. The third one is, again, you put it here and you try to poke from the lateral side. Okay, see your fat pad will be dancing. They're dancing. This is not my technique. Okay, this is, I read it in recently somewhere. So the fat pad will dance, but the tendon will stay. Are you able to see?
Yes, I can see.
Yes. So see, that is your fat pad, means above that is going to be your suprapatellar rhesus. Okay. So you
Yes, thank
follow
you so
it.
much.
Okay. And then you wanted to know about the retinaculum?
Yes, ma'am.
Okay, one more time. Okay. So now go back to your vastus medialis. Here your friend is vastus medialis.
Yes.
So I will increase the depth and then we will decrease it. So now I know that this is quadriceps tendon. Vastus medialis will be having a downward, extension. So I will just make vastus medialis my friend and I will just keep on coming down, 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 until it just goes away. And here I will reduce the depth. So I don't have a jelly here. So I will go back to vastus. Okay. Just a second. Okay, so that was the vastus. Just concentrate. I can just make the depth a little more so that you will be able to appreciate. So this is the vastus medialis. Let it go off, okay, because we don't want its friendship anymore. So once it is going off, now you will be able to appreciate the retinaculum. This is your MPF. Okay.
Yes, ma'am.
Easy. So
Yes,
make
ma'am.
your
Yes.
vastus medialis your friend. Then you don't have to do anything. Otherwise, you'll keep on finding where is the retinaculum. So it's always better you follow the medialis, come down. Let the medialis go off from your view. Automatically, this will be taking you to your medial patellar retinaculum.
Thank you.
Okay. So anything else? Or we can just quickly go through the pathology section.
Ma'am, do you recommend parapatellar approach for any sort of pathology?
No, I have stopped it.
Okay. And and
I have started now. If you will see the recently, I should say, Stanley Lamb has come with an infrapatellar approach also. Okay,
okay.
but I don't know. I'm much more comfortable with the suprapatellar till date, and I follow this only. That
Okay.
was like what I
Infrapatellar.
have shown you. Yeah, you can come from that side. See,
Yes.
and there is one more, which is by. I don't know, they have published a paper also, but I'm not very much comfortable about that. So I do not follow that approach also. So here also you can come because that is what you are seeing is the joint. Oh, sorry, I have not shared. Let me share
Yes.
this. Yeah, I'm sharing. Because now so many ways of, see, here is the joint. So you can come from the, okay, my annotations are not. And I will show you one more thing. Thank you for reminding that. That is very much important, which I have forgotten. So you can come from this side also. You can inject
Okay.
here. Okay. But I don't
Okay.
know, like I have done 2 or 3. I used to do it before, but now I have stopped it because there are so many ways to identify the suprapatellar. Rhesus have come even though you don't have a fluid. Like how I have taught you, like 3-1. And then you can just do a hydrodissection with a small amount of normal saline and you will be able to find it out. And this retinaculum, I recently, I don't know, because I need to do it on a, I think a larger group of individuals. That, this retinaculum, when I was coming, now they were having post-injection pain was too much. When piercing the retinaculum, like it was very much painful for them.
In
So I don't,
parapatellar.
yeah. So that was the reason I just stopped going through this and I inject in suprapatellar and even the PRP, everything is so good. I don't know. I really, I have stopped using any other approach and I'm very much going back to my, the level from where I started ultrasound and I feel it is much more easy. And, because the trauma is also very much less. How I do it, like, I keep it here. Then supposedly, if this is your Rhesus, okay, so this Rhesus is gonna come, I'll freeze it here. So now I'm able to see supposedly the Rhesus at a depth of almost 1.8 centimeter. So if this is my, probe, I will exactly measure 1.8 centimeter. I will just poke my needle straight, okay, and I will be just reaching here within fraction of seconds. So I think, I don't know, I have started feeling that this is a very good one as compared to the other approaches. Okay, angulation also is very easy. Everything is comfortable. Okay. Second thing,
Okay.
yes, I have forgotten to teach you one thing is you can see even the patellar cartilage also. Okay. So put your probe in a craniocaudal direction. If this is your medial, border of your patella, so you align your probe exactly here in the craniocaudal direction like this. Okay. Then you need to push it from the other side. Mali, you thoda sa relax kar. But I will just do this. But time mat kar. Okay. So here you will be able to see the patellar cartilage. Do it in the extension, not in the. Are you able to appreciate? Because both my hands are occupied. A bone, and over the bone, are you able to see an hypoechoic thing? Everyone?
Yes, ma'am.
So that is your patellar cartilage. Okay. But if you will flex it, you will be this, taut. So you will not be able to see it nicely. So do it in the extension. Put your probe in the craniocaudal direction. Push the patella from the other side. So that, because how is the cartilage? If this is the patella, this is the cartilage. So if you are pushing it from the opposite side, then you have to just I should say the footprint should be facing towards the cartilage, and then you will be able to see it. Second thing is the trochlear cartilage, which I have forgotten to show you. For that, you need to do a 90 degree of knee flexion. Okay. So if that is the 90 degree of flexion, you just put your probe. If, you know, with flexion, if you really don't know where your patella has gone, again, I will tell you, nice way, so that you don't know. Everybody by this time know where is the patella. Okay. So your patella is dipping, right? This is your patella, that is your quadriceps tendon. Fine. So
Right.
you can very well even see the trochlear cartilage here also. This is your femur condyle. So at this position, you just rotate your probe and you will be able to see. Supposedly you miss it. So that is another way of finding it. Then evaluate this cartilage fully like this. So see how beautiful his cartilage is because he's young. Okay. This whole is the cartilage. Evaluate. Look for any kind of deposit within the cartilage. Over means here or here. So that is going to give you an idea about the crystal depositing diseases. And see, here also you can find out your quadriceps tendon, make use of your anisotropy. So you will be able to see your quadriceps tendon also. So that's all, I think. So when I was looking at the trochlear cartilage, my probe was in short axis, aspect marker towards the lateral side.
I have a question, Doctora.
Yes.
Regarding the suprapatellar approach for the suprapatellar recess, we can go from the medial and the lateral or only from the lateral side?
I prefer lateral, but yes, people, they go from the medial side also. I do not like it going from this side. Okay, again, my camera is up. So let me go. You can put your probe. You can go from this side as well. But the preferred side, the recommended is the lateral one, not the medial side.
And from the lateral side, any concern regarding the iliotibial band?
No, because iliotibial band is going to be, almost. Okay, I can show you this. Let me see if I can try showing you. So that is your iliotibial band. Okay, the top which you are seeing. Fine. This is your iliotibial band. And if I'm doing a cross section of it, right? And I'm coming to this side. So where is it? It is somewhere superficial. I have to go here. You got it? It is much up. I'm going little down. Are you able to understand or not? No answer.
Sorry, Doctor. I was not following. Sorry.
So I'll do one thing. Let us finish the lateral side. Then I will show you. Okay. So I think that will be pretty clear to you because I cannot go much on the lateral side today. So I will show you where exactly your lateral iliotibial band in the short axis will be. Okay. And how you are going in the short axis and where your recess will be, because that will be little up. Okay. We will not be piercing the iliotibial band to go to the recess. Okay. Is it clear?
Yes, Doctor.
Okay. So wait till next class, then we will see them from the lateral side as well. Okay. But it is quite, I should say, safe to go from the superior lateral aspect. Okay. Because we will not be that superficial. We will be going down. Okay, let us now quickly see the pathology. So we learn about this thing, the quadriceps tendon in the longitudinal axis, and I have told you that it becomes very important for us to know the different layers of the quadriceps tendon. Okay, so this is a picture which is basically showing that you are having some problem in this layer, okay, somewhere here. Oh. Somewhere here. Same thing you are able to see in the short axis as well. Do remember, in order to call a tendon pathological, and you can see it in the MRI finding as well, right? So you need to have a problem in the tendon, both in the longitudinal axis and in the short axis. So when a patient of quadriceps tendinopathy is going to come to you, he will be having an weakness in the extension. Okay, so don't ever think of always the radiculopathy. You might be having a problem with the tendon itself, right? And there is something called as extensor lag sign, which will be positive for this patient. You put your finger over, the base of the patella, that side will be painful for this patients. Then you can put your probe, you can find out whether there is any kind of tendinosis, whether there is any kind of partial tear, right? If it's a complete tear, then full loss of extension will be there. So clinically also it will be very much evident to you, but when it is a weakness, then you can put your probe and your ultrasound will really help you a lot in that. And this is something which is showing a tear, right? This is how it looks like under ultrasound. Then about the patella, I have told you that you will be able to make out the fracture. So fractures will be a step of deformity, okay? Step up deformity will be a fracture, and this side will be taking up the color Doppler, right? And this is the same picture which you have seen in the X-ray as well. Then about the osteoarthritis. So osteoarthritis will be more common. It is more common in the middle-aged women, okay? And they will be having a difficulty in sitting on the floor with the crossed legs. And if they have to get up from the floor, they will be just taking the support of the hand, walking up, climbing the stairs, right? Will be very much painful. And if it has progressed to a later stage, then yes, they will be walking with some kind of calipers, right? And they will prefer not to sit on the Indian toilets, and they will prefer the Western ones. So these are some of the features which you will see. And when you examine, there will be a joint tenderness, right? And there'll be a diffuse pain, right? Sometimes, but it is more of the medial side, which is commonly involved, right? The first time of, I should say the initial time, otherwise, they'll just complain of a vague pain. If it has become chronic, okay, so they might be complaining of a burning sensation, allodynia. So all this should give you a clue that you are dealing with a patient of a chronic knee pain, which has got an acute exacerbation, right? And this chronic pain, this patient might be having sensitization, and that is the reason they are just complaining of a burning pain or, allodynia. So do not think that they have just gone mad and they're just like that saying it to be a, I should say, burning sensation or allodynias, right? And when you just order an X-ray, do look for your osteophytes, how the osteophytes will be looking to you under X-ray. So I have just made it here. So these are the osteophytes which you will be looking at. You will be looking for the irregularity here, the narrowing of the joint line, right? So look for all those, and then we have a grading. This you can just go back and read it because it is more of an observer biased rather than, the grading itself. It is just to your eyes. By the more and more X-rays you will see, your eyes will become tuned. Okay, so this will be grade 4, this is grade 3, this is grade 2, and this is grade 1, right? So you can take a screenshot, read it. The more ugly gist of this slide is, more ugly the knee is, the worse the prognosis of your regenerative therapies. Then do ask the patient to decrease their weight. It is not a body shaming. You can just tell them that if you are going to reduce, weight, then there'll be a 10% reduction in knee OA per kilogram of your body weight decrease. So that is scientifically proven. I'm not just trying to body shame you. Like that, you tell them. Then if you want to go for the treatment, yes, here the physical therapy plays a very important role. And we do not have a recommendation by any of the societies for this chondroitin and glucosamine sulfates, right? And you can give paracetamol, you can give duloxetine if you're expecting it to be a sensitization, chronic pain patient with sensitization, please start duloxetine. Then you can give oral NSAIDs, topical NSAIDs, and intra-articular steroids you can inject. But if you see the recent literature, they say that corticosteroid causes the degradation of the chondrocytes. So they make the patient more susceptible for your TKRs. So it is not advisable. And then viscosupplementation, though we do not have a recommendation by any of the societies, but still there are many research papers and they have said that viscosupplementation, though it's an off-label use of it, it has got very good results when you are injecting the HA, hyaluronic acid, along with your PRP. Okay, so these are the few articles. They have laid the importance of what exactly I have told you regarding corticosteroids. Then this is about the viscosupplementation. Its normal molecular weight is kilodalton, okay? And it is present in a concentration of 2 to 4 mg per ml. These are all the off-label use of, off-label I should say the good effects about HA, which they have proved in vitro studies, right? And there are 3 kind of molecular weights of it, right? That is less than 1,000, 1,000 to 3,000, and greater than 3,000. Now, I would like to tell you one thing, that whatever, these are all the brands, you can take a screenshot, and this I always say in all my classes, that these are the different brands which are available in the market. What you need to see that this is bacterially fermented, okay? It is a cross-linked and it is a high molecular weight, okay? So these 3 things in any of the HA you see, and then you can just inject, okay? I give PRP with HA first injection, followed by PRP second injection, followed by PRP third injection. 3 injections in a 1-month interval. And we do not have any recommendation, so you can follow whatever you feel like. So this is something I have seen recently, and just to tell you that you do see these kind of effusions, right? Such huge effusions, then they should, I should say that they should alert you that these kind of huge effusions will not be present just because of osteoarthritis knee. This patient had a meniscus injury long back, and still, he hasn't shown it to anybody, and he was just be at home. And then he came to me and I examined. I could see so much of even like pain. It was so painful, he didn't allow me to examine also. It was so much of allodynia because he was suffering from this pain for a quite long time. So, if you see, like supposedly he has not allowed you to examine, but he has given you a history of twisting injury, okay? And when he's not able to bear the weight, right? He's not able to stand. And sometimes he get even the mechanical locking also, that he feels that his knee has got locked. You put the probe, right? And you just happen to see so much of effusion. So that should alert you. Second thing, whenever you are looking at the effusion, this is another patient. Okay. So whenever you are looking at the effusion, you try to compress it. Now, how I will be doing now. So you try to compress it. If it is compressible, displaceable, no color Doppler activity, it is just a simple effusion. You are not gonna bother that, oh, I am looking at an inflammatory pathology condition. Because if you look for the recent articles about the osteoarthritis, they do say that in this individuals also you can get some amount of, the synovitis, and that will be the reason for this fluid, even in the osteoarthritis individual. So if it is a simple fluid, you are not able to see anything, right? It is compressible, displaceable, no color Doppler activity, then you can be a little bit confident inside that you are not dealing with a patient of inflammatory arthropathy. Then if you want to give the intervention, this I have already taught you. Second thing is about the jumper's knee. Jumper's knee is another name for the patellar tendinopathy. Right? So they will be having the pain, sharp pain, okay? and that will be distal to the lower apex of the patella, and this will be worsening after jumping, running, walking. And you can see even just a tendinosis, and you can see even a partial tear. So treat it according to what we have been learning for the treatment of the tendinosis and the partial tear. So that is the reason you need to evaluate the tendon fully if you're just looking only in the longitudinal axis. I do not see the tendon only in one axis. I go for both the axes together. Then yes, you can go for it in the longitudinal axis, the intervention. I prefer short axis because see how easy it is. Okay, you just put your probe and this needle is also in plane. You will be able to see the tip and the shaft very nicely. Prepatellar bursa is more common in the housemaid. It is another name for the housemaid's knee, basically is prepatellar bursa or the carpet layer's knee. This patients will be having a pain which will be over the top of the patella. So do remember when you are examining, you need to apply simple, I should say, very gentle, be very gentle when you are just evaluating it. Okay, this we have seen in the short axis. We could not see any of the pathology. You can go back to the recording and you can see. So see here, you have a collection, right? And if you're going to press so much, if it is just a simple fluid, then it will get displaced, it will get compressed, and you will just not be able to see anything. So whenever you see any fluid inside the bursa, okay, bursitis, always local with steroid, okay, until unless you are seeing it to be an infective one, like he is having high grade fever, there is a redness, there is, it is warm to touch. So it is infective, no steroid, okay? But all those things are not there, right? But you are able to see this fluid, and then you need to aspirate it, send for analysis. Never just throw that fluid, do send it for analysis. Then the infrapatellar bursa, another name for it, it's clergyman bursitis, more common in people who are just kneeling or just crawling. Here also, you can put, again in the superficie, in the short axis or in the long axis. I do not prefer this, okay? Though I have put the picture, I do not prefer this because the angulation is very difficult. Wherever my needle will go straight, I prefer that position. So this short axis is the one which I prefer. How exactly your deep and the superficial will look like? This is your deep and that is your superficial, okay? Then on the medial knee, yes, we have seen the superficial layer of the ligament. So ligaments, you can have a sprain, you can have a tear, you can have a complete rupture of the ligament, okay? So again, go back to how I have shown you the short axis, okay? So in the short axis, if you are looking at so short axis, if you are looking for, it is not looking hyperechoic fibrillar, okay? It is looking more of hypoechoic, even though you have done the toggling, it is taking up the color Doppler activity. It might be the sprain of the ligament. Then, okay. So this is important, which I wanted to tell you. So we have seen, I should say the meniscus, which was going down. And these two ends, they were just staying together when you are testing for it, even though you can do a 90-degree of flexion, but in order to test for this collateral ligament, you do a valgus stress, means you just pull the, I should say, the leg towards the lateral side. If there is no opening up of these two, femur and the tibia, they are just staying together, your ligament is intact. But if there is a widening in it, it means you are dealing with a patient who is having an injury of the collateral ligament, in which you can very well see also, if you really know how to identify it. If there is some kind of injury, you will be able to make it up. If you really know how to look for it in the normal, like how exactly the normal will look like, then if there is anything abnormal, definitely you will be able to pick it up. Okay, so this is what I was telling you about the meniscus. If there is anything, see how it is bulging up. Go back and learn this meniscus hopping. Okay, this is very important. This will really be helping you a lot in your day-to-day practice. Then this was the pes anserine. I have told you the alphabet E. Okay. So this you will be able to see very nicely. If there is any enlargement of this fluid, if there is a fluid in this bursa, you will be able to see it definitely. Never, never, ever you will be wrong. Bang on you will be, okay? So if there is, patient who is coming to you with these kind of pain over the medial aspect of the knee, over the tibia, okay? You put your probe when you happen to see something like this. This is nothing. It is pes anserine bursitis. Then you need to go for a local with steroid. That's all. Patient will be pain-free, okay? So that's all for the pathology. And I have one question. Somebody has asked me. Where is the chat? So someone asked me something. Which grade of knee we can give? Okay. So I'll tell you one thing. If it is grade 1, okay, somebody who is coming to me, because it has been now many years since I have been practicing. So not only the referred patient, I have my own patients itself. So if the patient is coming to me for the first time, they have not taken any kind of, drugs and anything, before, then I prefer to go for the conservative one. I do not just inject there itself. I always give a trial of the conservative. I send the patient for physiotherapy, ask them to go for the quadriceps strengthening exercises. I give them NSAIDs or paracetamol depending on the comorbidities they are having. This is the first thing I do. Supposedly, they have already taken all those treatments and it happens to be grade 1. If it happens to be grade 1, I just inject only the hyaluronic acid. Okay. Supposedly, if it is grade 2 or grade 3, I prefer to go for a PRP with HA. And then I repeat it after a month PRP, and then after a month again a PRP. Means 3 injections of PRP. First injection of PRP with HA. Supposedly it is grade 4. Okay, I do not entertain them that go for the regenerative, because I always ask them to go for a TKR first. If they are not willing to go for TKR, then I usually do the intervention. Okay, please show some intervention demonstration also for every module. Okay, we'll do it. Actually, there is so much to teach, it's like only 1.5 hours, what all to teach. So I prefer that, I should teach you the basic, basic in the sense the normal sonoanatomy. So that if there is any kind of pathology, any pathology, you will be able to pick it up. And treatment more or less in, MSK remains the same. If it is for your tendon, you need to find out whether there is tenosynovitis, tendinosis, partial tear or a complete tear. Same goes with ligament. If it's a joint, you need to find out it's an inflammatory or a degenerative. Degenerative, go for it. Regenerative, it's an inflammatory. Try to find out the systemic, right? And if it's a nerve entrapment, go for hydrodissection. So the treatment modality, especially in the MSK, it remains the same. Okay. First is you should know how to identify that structure. Second important thing is how exactly you are supposed to put the needle. So needle, you can have it in plane or you can have out of plane. In your initial days, I would suggest you go for in plane. Okay. In plane is very easy. You have your structure and your needle is always parallel to the, structure of your interest. You will be able to see the tip and the shaft, right? And if you know the structure, needling is just an art, I should say. Okay. So it comes and you can practice needling in tofu. Okay. You need not have a gel phantom. Okay. And you can just take 2 tofus, bricks of tofus. Tofu is soya paneer. You can take that, put 1 coin inside, okay, between the 2 layers. Put your probe and try to put your needle. Poke from every aspect, how wrong you can go. And do remember when you are, I should say, let me share my screen and I will tell you something which I think I have taught you before also. Where is my Zoom? So I'll simply tell you one thing about the needling. If this is your probe, right? Try to keep most of the time your needle. If this is your probe, let me get a Okay, I have speech. Okay. If this is your probe, okay, so the beams are coming like this. If this is your structure of interest, you can come like this one way, okay, by measuring the depth of this structure from the skin, right? Because your probe will be here on the skin. Second thing, you can come this way also, okay, but this angulation should be less than 30 degrees. Okay, don't go more acute. If you are going to go more acute, your needle, you will not be able to visualize your needle. Okay, that is the another one. And there is something called as gel standoff. Maybe I'll just teach you in my next class how to do the skying of the probe also. When you have put the needle, you are not able to see. Then you can do a skying of the probe. You can do heel toe maneuver if you are not able to visualize. So these are the maneuvers I think we have taught you in the basic class. And when you are using a gel standoff, make sure that your gel might be getting stuck into the tip, and maybe you are injecting your drug and it is not, you are able to take that gel out. So before injecting the drug, I would always suggest that you put your normal saline a little bit just to see your tip is exactly there, and then you inject the drug rather than wasting the drug for hydrodissection. And Dr. Caroline, I will suggest books. You read them, okay? Because if you know the normal pathology comes automatically, you keep on seeing the pictures, and you will know that there is some problem in this, there is some problem in this, and then it will come. So have lots and lots of pathology pictures that should go through your eyes, so that if there is any problem, you will be able to pick them up. But before that, I would suggest that all of you should learn the normal. This is equally important. Normal structure is important. Okay. And like for ECRB, I'm giving you an example. ECRB, if you'll put just a probe in line with your lateral epicondyle and your radial head, you will miss ECRB, because ECRB is much superior. You need to move your probe much up to look for the ECRB tendon. And you will see that, oh, this patient, I'm expecting it that this patient is having lateral tendinopathy, but he is not at all having that. I'm seeing the fibrillar pattern very nicely. So every structure identification is important. This is what I'm trying to teach you through all my classes, because so many things are there in the normal itself. If we don't know the normal, we will not be able to pick up the abnormal. And I will be sharing the books, and I'll take care that in the next class onwards, I'll just show you some of the interventions. Okay. And now any questions, if you have, you can ask me, or we'll just say goodbye.
Yeah,
And we'll meet.
and one question. Ma'am, regarding genicular nerve, if we are giving PRP knee for OA, so should we do genicular nerve block also for
Some
the pain?
people are, some people are doing mixture. Okay. And we are planning to post a video on the genicular nerve, because see, I have taken the medial aspect, they will be taking the lateral aspect. So we will make a video on the genicular nerve especially. So we will be posting that, how to examine it, how exactly you are supposed to go for the RF if you want to go for. So we'll be posting a video on that. But I will tell you one thing, that there are many people who are doing even the RF of that, and then they are injecting the, I should say, PRP also, HA also. So there are no guidelines for that. It's like people, they do whatever they feel like. They feel that if they will give a cocktail, it might be working well. But I think if you are working on that, then you need to publish it. You publish it, and then we can just appreciate that. Okay.
Yeah. And one thing more, in X-ray, like, can we do PRP both knee for bilateral OA, or we should give in one knee, one sitting, and after 2 weeks, next knee?
No, I usually see, these are all practical. I'm very happy you asked such a good question. What usually happens if a patient comes to you with OA knee, right? If she's a lady, you ask her whether she's any whether she is having any house help or not, whether there is somebody at her home to take care of her or not. Usually what happens is like, I usually prefer to give them a rest for, not allow them to do the weight bearing activities for initial 7 days. I ask them to walk with a stick. Okay. If I'm doing it for a unilateral, and if I'm doing it for a bilateral, I'll just ask them to, take a support of someone, have one stick in one hand and take a support of the other, just to walk and go to the washroom just for 7 days. And then they can start walking slowly. But if they do not have any help, I usually do not do bilateral together, but there is no harm. You can do it. I have done it for many of the patients, like the mother-in-law is staying with her daughter-in-law and she was there to take care of her. So I have done both together, right? And if not, I usually do it for one knee at a time, which is more painful. And I tell them that, once I'm doing it for only one knee, and you might start using this because it is going to become good. And then you might be having an excessive pain on the other knee. So I tell them, and then I leave the, I should say they are the one who should be telling me whether I should go for a unilateral or a bilateral. So I think you can also customize your treatment. There is no hard or fast rule that you cannot do. Yes, you can do bilateral together, but yes, keeping the practical issues in your mind and you explain them to your patients, I think that is going to give you the best outcome.
And stick on opposite side.
No,
support-
stick on one hand and let the other person hold her.
Yeah. Like stick
Support
on
system. Yeah, because if I'll tell them to walk with a walker, then, walker is very costly. Unnecessarily an expenditure. So that also we have to take care. So stick is like, many of my patients who come from the village, you won't even believe they bring that, because if I tell them that you bring a stick, so many a times they have bought that, the tree one, we have that bark, so stick made up of that. Oh my God. I was like, okay, fine. You can just go ahead with that. So you need to have a support to walk.
Yeah.
Walker is the
And-
best if you can afford, but if you cannot, then you can ask somebody to help you out.
Ma'am,
Okay.
when you inject both HA and PRP, what is the volume that you inject? If it is
I am
unilateral and
actually,
bilateral?
I am injecting 3 ml because I'm using 30 mg per ml. So I give 90 mg. As I have told you, the high molecular weight, cross-linked and bacterial fermented. These 3 things I take into my account. And
So mono.
yes, in one go. And PRP, I have a kit. So that kit basically gives me 2 ml. Okay. And that has got a concentration of 7 times the one which this patient, the pre-injection PRP is. So pre-injection platelets. So it is like, it just makes them 7 times. So I inject that.
Any role of growth factors there? Like
I have
Okhara,
not used it. Yeah, it is there in the town. It is there in the market. People are using it, but I haven't used it. I don't know. Maybe I'll just have more of research on the growth factors before using it.
Because Okhara people, they are just
Yes, Vokard,
trying
there
to
is one
connect.
more company. They are behind, use it, use it, use it. But I don't
Okay.
know. I'm much more comfortable with PRP.
PRP.
They claim so many things. You need not have this activator. Everything will be. But I don't know. I need to get myself more convinced. Maybe if I'll get convinced, I will start using them.
Okay. Ma'am, infrapatellar approach, is it parapatellar tendon?
No, I'll share that article of Stanley Lamb. Okay.
Okay.
Where he has seen the patellar tendon and then he has tilted the probe so that he's looking at the trochlear cartilage and then he's coming from the medial or the lateral side. I'll share that article. It is free SS article, so I don't have any problem in sharing it. I'll share it. You can try it.
Okay.
He has said that he has used this approach when the suprapatellar rhesus, there was no fluid he was able to find out. Then he has gone for this approach.
Okay. Many of the surgeons, they do it blindly, injection, intraarticular
Yes,
injection,
they
and
will
they will
flex it. They will flex
Yes.
it, palpate the
patellar
tibial
tendon.
plateau. Yes. And then look for the gap and put the needle towards the opposite. Yeah, I have also done it. Don't worry. In my initial days, but now I'm not at all doing anything because I really don't know. My needle might get stuck in my ACL, right?
Right.
No effect. Why should I go for something, like that? I'm not I don't know. I'm much more comfortable with my USG. Now I feel I cannot do any of the blind injection. If you'll give me and tell me, madam, you do this, I am like incapable of doing any blind injections.
Sometimes I have tried to introduce the needle in that approach under ultrasound, but I could not find that whether my needle has crossed the fat pad and where
Pad or not.
exactly it is.
If you want to try, this one is good, Arindam, intrapatellar approach, but I don't know. Recently, I have read, I have attended one webinar, and that was by one of the very good MSK, person. And he was telling me that this is all, they needs to have a randomized control trial in order to give this condition a better one. So I just don't want to, practice something which is very new and not having a good outcome just on the basis of 2 or 3 cases. I cannot take that technique as the standard one. And that is the reason of not using it, to be very frank. So I will share that technique if you can use it for your patients and you can do an RCT comparing with your suprapatellar. I'll be more than happy, and just tell me the results. I will also start doing it because I'm a little apprehensive in going for a technique which doesn't have a good, which is just in the beginning stage. You might be having, because, when a new technique comes, it's like, oh, new technique has come, but how good it is, we will come to know once, we are going to have lots of studies and people are just, publishing their outcomes. So that is the reason of not using that. But I think it's a pretty easy, I'll share that Stanley Lamb's technique with you. I'll share that paper with all of you. And Dr.
Ma'am, this
Ankush, can I answer Ankush question first? Dr. Ankush, what I usually, if there is a meniscus injury, Dr. Ankush, I send it to my very good orthopedic friend and I let him decide what he wants to do. I do not inject any kind of regenerative therapy in the meniscus. I send it to my orthopedic friend. Yes, somebody was asking something.
Yeah, ma'am, with one kit, if we get 2.5 ml to 2 ml, so we can inject in both knee 1 ml each. It will be sufficient.
No, no. I inject 2 ml in both the knees, not one.
But 2 ml each. 2 ml each. So we will be using
because that is, see, I'm telling you all these things now, they are PRP, it is all the kits, how they have made their kits. Okay. So it's always better you discuss with the person, the manufacturer, how much exactly it comes out in this. And if you'll see, there are no recommendation for this also. Many people are using 5 times, some are using 7 times, some are using even 10 times also. Okay. So whatever kit you are using, you ask, how exactly, because they have all the things, for the knee, this much ml should be given. So they have all the, I should say, the written things, because they would have done the research, right? So I feel it's better if you ask the manufacturer. Like my manufacturer, 22 ml tube, I use 22, 44 ml. Okay, blood I usually take in 2 tubes, means 22 ml tube if I have to go for the lateral knee. And out of that 22, it is only 2 ml which I'll be getting. So that is how he has designed it. So I think you can ask the manufacturer how much exactly they have, how exactly they have designed there, because like Tricell has got a different thing. The Rescue Sciences, which I'm using, that has got a different one. There is a PRP, that Dr. PRP, that has got a different one. So it's better if you ask, you follow the things which the tubes or the company which you are using. Okay. That will be the best, I'm telling you. Yes.
Ma'am, one basic thing, like if old middle age patient come with a OA knee, grade 2 patient, and before injecting PRP, and if it is in very much pain, so after PRP pain will increase. So what basic, well, one thing, what basic?
See, obviously if it's an OA knee, pain is going to be there, but if it's an excruciating pain, okay, so if it's an excruciating pain, give them NSAIDs, okay, for a week if there are no contraindications to give the NSAIDs. But repeat the PRP, give the PRP after a week so that you have a washout of the NSAIDs from their body. And what I usually do is I start duloxetine, okay, first, so that at least there is one drug which will be taking care of my sensitization also. Because many of the times, even I keep telling it in all my classes, that my mother-in-law had this typical allodynia, okay, at the site of injection. Imagine. She keeps on telling me my pain has gone, but this needle is paining so much because she was in chronic pain. And it just happened, I think, 5 years down the lane, I have given her. And that time, since then, I usually start duloxetine for my patients if I see that they are having some kind of sensitization, because I know that needle prick will always be there. And if they are in excruciating pain, obviously I start NSAIDs, but believe me, this PRP causing excessive amount of pain, in my practice, if your needle is perfect in the suprapatellar recess, okay, and if you counsel your patients that, okay, this PRP, you know, how you can tell them, how I explain, it sounds a little funny, but yes, it helps you in your practical life. That I usually tell my patients that PRP will make collagen. So collagen is like your, sand mountain, which we usually make. And the river which is flowing is the weight-bearing activities. So in your initial days, if you do more of weight-bearing activities, what will happen is your mountain will be just, will no longer be there. So you will not have a, I should say, the collagen getting deposited. Okay, one thing. Second thing, I tell them that, see, PRP is like, it causes inflammation and then it causes the deposition of collagen. Means it will be causing some kind of problem in your knee initially, and then it will be healing it. Like how after the surgery, we have an excruciating pain and then it goes off. So that is normal. And if you are having very good, it means you're going to get the best results. So this counseling is also important. And if you counsel your patients, you will see that, they will be just bearing that pain. They will not be calling you in the midnight and it is paining. And I give them, paracetamol 650 after the procedure. Okay, so that at least if they will take the tablet, at least that placebo effect will also be there, that they have taken the tablet and it will not be paining. And I tell them that if it pains more, you can take this tramadol as well, but no other drugs. So all these things, if you will tell them, your headache will be a little bit less.
Yeah. Gabapentin can also be given for
No,
sensitization.
why? We don't have, we have seen the recommendations, no recommendation of gabapentin. Only recommendation of duloxetine. Yeah, that is why I'm writing only duloxetine. And duloxetine, when you are writing, do tell them that duloxetine, if you give in 100 patients, okay, so many a times what happens is, 70% of the individuals will not have anything. 30% of the individuals will be having a nausea and vomiting. Or not even vomiting, nausea will be there. So on the first day, it will be 5 on 5. Second day, it will be 2.5. Third day, it will be 1. And fourth day, it might go off. But for you, sometimes it might be taking 5 days or 6 days. This you explain it to the patient. Otherwise, the moment they're going to get up from the bed, and if they're going to be there in the 30%, they are going to call you up and they'll say, what medicine you have given me? I am feeling so uneasy. I feel like I'll be just vomiting out, but I'm not able to do so. So that feeling is so horrible, I'm telling you. But if you'll explain it, then they will understand it. Okay, madam has told, okay, so this will be a normal phenomena. So I'm falling into the 30% of individuals. And start not with the 20 mg, I start with half. Okay, means I give 10 mg and then I increase the dose after 10 days, I make it 20 mg. So this, yes.
I have a question.
Yes.
Yes, I myself have a tear in the supraspinatus. And I was doing an echo, the orthopedic surgeon said